You can, oh, let me change. This is your slides, right? Yeah.
Okay. Hi, I'm Vanessa Gonçalves. I hope everybody can hear me. Okay.
You can, there's a mic. Okay.
Oh, it's difficult. Okay. Yeah. Now it's better. Yeah. I have this low voice. I'm trying to get better. I think what I'm going to say is pretty much what's covered for the first talk, but I think we'll the way I planned was like to share my own experience. I have been in many mentor-mentee events and people and even more informal requests from the trainees I'm involved somehow. They like to hear and they feel, I think they feel, oh, someone like me, right? And she make the point to get the position that I want to be, right? So I think that it was a trajectory with a lot of barriers, unknowns, right? So I feel like I'm going a way that a lot of curves to go to the same place. Some people go in a straight line. But I think we learn so much with the barriers that I think, and I think I'm another person since the day I arrived here at CAMH, just across the street, right? So how things will change myself and help me to be, I hope, a PI that I haven't had to guide me to the direction to go more straight in the line to have our dreams, right? To get the position where you want to work, right? So this inclusive environment for trainees is something that is so important that we have no idea when, I don't know if the PIs have idea how much is important when you are come from another place, right? So, like I arrived from Brazil and I barely speak English. You can see even now, you will see that is a lot of problems, right? But now I'm not shy anymore that, I feel comfortable well, I'm not Canadian, I'm Canadian now, but I still like came from Brazil. So how I became more comfortable with all the difference to be someone that was always outsider, right? So I arrived barely speaking English in a place very close. People don't talk too much each other. So I arrived, and the person that is in the charge to receive the trainees, she was on maternity leave, for my luck. So, but they not even told me that has a person on maternity leave, so things will be a little bit mess in the beginning. So I thought I was with no direction, right? So I didn't know which trainings I have to do, what I have to do, who I should talk, and everybody went for a conference in Greece. So I was alone in this environment, don't know what to do and how I'm going to survive here. Completely different from Brazil, right? I was more familiar with everything I know. I could anticipate what's going to happen. So I think the most important, like as a PI or a teacher, like do the students, the trainees came for the first time, even they are from here or from a foreign country, do they have everything they need? They know how to arrive to the place. You have someone to receive them because, for example, I don't know if you have been at CAMH, it's like a maze. All the doors are blue and you get like lost very quickly, right? So it's so they know how to arrive. You have someone to receive, right? Show the table where they are going to sit is appropriate, not what they're supposed to have. What's the package, right? What I should provide, what the institution will provide, what the PI will provide for us. What's my rights here, right? It's something that's not maybe clear for people here because I know here we have very good PIs, but it's not necessarily clear, right? And so first, do they have everything they need? Workstation, the keys, the card, do they have everything? They know which course they should do. Are they aware about that? They know the codes. If you have a code in the hospital, you need to check if they are comfortable with that, right? So especially if now with all these, the environments become more diverse, we have a lot of persons come from different places with different perspectives in environments that's completely different than what we have here in Canada, right? So we need to have this a sense of trust, respect that we here we have a lot in Canada, but and how we develop this sense of belonging, how we make the trainee to feel comfortable to that's okay if you don't speak English very well, we will make a way to understand you. How you make this person feel comfortable as soon as possible, because as soon you feel comfortable, you can be yourself, things will change, right? You can show how much potential you have, and we are going to develop this in the best way you can. Right, so the lab I came for was like a very diverse environment. So the PI, he's likes to work with like foreign trainees, so it's very open to that. And so I was feeling comfortable in terms of I'm not the only one, so maybe I can learn with the other one's experience, right? The PI per se, he's very nice. He was open. He even trying to learn a few words in the language of each of his foreign students. So he knows some, now he knows a lot Portuguese because he has been exposed to Brazilians a lot, but he is always knows something related to the country where the person came from. He learned how to speak. He asked to teach him few words. So he tried to make this, and he talks a lot. Right, so sometimes when we go, right, when we go for like what some people get stressed out with him, but for us, especially when you are starting, so I has this PI that asks, how is your family? How is things in Brazil? How you do that? How was the environment? So he was trying to get information. How was the environment of this person was, right? What was the difficulties? What is normal, right? What is new for her? So I think like he tried to connect with you. That I think this is really great, and we connect with him very fast. Is everybody get very connected? He's easy, open, easy going personality. So you feel like if you have a problem, you feel comfortable to talk. The first time you see him, you feel comfortable, right? He have like this ice broken naturally inside of him. That's really something that we learn a lot with him, how to be so inclusive, right? In a time that inclusive was not a word that we heard, right? It was completely like if you have a good PI, good for you, but there is not else we can do for you. Right, so this was very important for me. Like I learned so much to how to embrace the new people, how to make them comfortable with him, right? So this part was easy and very like thoughtful, right? You feel comfortable, right? And as the group is also from different places, we get surprised how much when we talk in this, like she said, the social events, how much the cultures are not different, right? And how much we have stereotypes of like people from different places. And when we talk, we see that pretty much we're the same. We have pretty much almost the same values, and we understand how things are different, what we should talk, what we should not talk. So we establish the barriers about this we should touch, this we shouldn't, in terms of the freedom of the persons in a nice way. Right, everybody feel comfortable. We laugh about our Brazilian way to be, and they also laugh about their way to be. So it's nice how this you make the conversation open. How much we learn, and we learn. Oh, this person he doesn't like to be treated like that, or this person doesn't like to ask this kind of questions. So we know the limits for each person naturally, right? So communication, be open to. Sometimes now that I still hybrid, I have this feeling that when I go to CAMH, I go to talk, right? I want to see how people is doing, how is they are doing, and it's more like how they talk, right? It's more like interact with the peers that you are part of. Sometimes if we are part of teams, we just meet online. They say, oh my God, I'm seeing you in person now. So right now we are losing a little bit of this in person and important, make the connection much more strong, right? So even with the students in the classroom, we try to, as we have a lot of hands-on experience classes, we try to, as we connect with them, trying to help, we learn a little bit more about how the kind of students they are, the difficulties, and then sometimes myself and the TAs and the team that is helping, so, oh my God, they are having more difficult than we were expecting. I think we should go slower, right? Because they are not in the speed that we thought they will be. So then they don't know, but we reframe the class before they go for the next class to make sure that everybody is following, and they can really learn it and not just copy and paste things. And in the end, they have like pipelines, they have no idea how to fix problems and everything, right? Also, it's still up to just the barriers to make everybody comfortable. Another thing is like when we are present, we have like all the right size of the font. Is everybody with like able to understand? Do we have like people that is just arrived in Canada that might have some difficulty to understand? So how much we should put in the slides for this person that is still catching up with the English can get the keywords to follow the classes, right? In our presentations, also in the lab meetings, everybody in the same lab, should we start a little bit more basic, right? So we like to go to feel like what is the team I have right now? Is more students, so we need to keep explaining all the pipelines. Sometimes as a group, and we see that a student is having problems with a specific pipeline that we run, we ask the student to present, and then we, go like that, pay attention this. So they shouldn't get more comfortable, like to present, right? Have to think because now it's have to explain, right? So in this way, and do this in a nice way that the person feel comfortable, not like in an auto test, right? So we're trying to make sure that they understand the environment they are, what is their role. As soon the students start, is also nice, as my experience, to know what exactly is your role in the team, right? So we have our common purpose, like we are together, bring new expertise and teach people to know how to do mitochondrial genetics analysis, but what's the piece of each of the students, right? Or the postdoc. So we have this idea, we want to advance science in terms of knowledge in terms of mitochondrial genetics across neuropsychiatric disorders. But is everybody overlap? No. Your role is this one, so you are going to do this person covers that. So together you have this piece of the puzzle that we are trying to put all together. In the few years we are going to report our findings, right? So they don't feel that they are just a learner, right? But they can feel that they have a responsibility to the team. So, okay, I'm contributing with that. So it's a nice way to, it's nice to give you motivation, right? You are doing something that's good, that will help, right? You are not just one more in the team, right? So, and when they come with some new ideas, this I also learned with my my PI, that was my supervisor. You give them credibility, right? It's where the new ideas will come, all this innovation. They have backgrounds different, that they see things different, and it's very nice. Because when I came with my my expertise, my PI was, yes, was nice, but took so long to go to the lab and do something with that, right? So I had to go like around, right, to get to the I think this worth to be tested, right? So it's good that you works as a trainee, right? You have to convince someone that the idea is good, right? It's a great training, I think. Right? So it's good to but I felt many times not be listened, right? So this is it's good to you try to accommodate a little bit the ideas, of course, as makes sense, and you have opportunity to offer this to students, but helps to stimulate the creativity in the group, right? And one other thing that I tell everybody that talks to me and wants to understand how things work is very, but not sometimes the PI is too busy and think that gave you all the information you need to get started. But sometimes you need someone from the team, someone that's leaving all the burden, right? Because I was, when I started, I was trying how things work, what is, people were applying for a conference. I have no idea what the conference was, and nobody was talking because they were busy. And then the day after the deadline, which I remember 15 years ago, and I still remember, they said, did you submit abstract for SOBP? And then I asked, what is SOBP? I came from a different field and I have no idea which conference to go, right? And no idea there is a deadline. I saw everybody was busy and thinking I should be busy too, but I have no idea what was that about, right? And then, it's the Society for Biological Psychiatry meeting. Everybody goes. I am not going, so I'm with the first social event for the group that I will not be there, right? Even be like by the time of the conference, 6 months later. Because nobody told me, oh, we have this conference coming, so prepare an abstract, right? You may have some pilot date. So it was something that I get like, oh, why nobody told me, right? Everybody was busy. I was there like, what are you doing? Right? So it was a little bit, I was trying and not find like a person to explain me what's going on. I know it's not in Brazil anymore, but I think this not make sense here. And then I have this angel. He just had like also came from outside, and his name is Vincenzo De Luca. I don't know if you have talked to him. He's very nice, and I think he saw myself lost, and he recognized he also passed for that when he started a few years before me, and he told me, Vanessa, let's go for a coffee. And I thought, I don't drink coffee. And then he said, Vanessa, everybody, someone call you to go for a coffee. It's not about coffee. It's networking. So, oh my God, I said so many no's. I didn't know that was, like you have no idea, like when you are new in the environment, right? And these are ways to socialize that you have no idea, right? It was never about coffee, right? Although now I'm addicted to coffee, right? So, and then he took me to the coffee, and then he was saying, oh, so you are here at CAMH, so how is the things work? So you have to do this, and this. So you have to create your own research line. You have to have so many papers, grants. So he have to gave me directions that nobody gave me. And then I have a lot of, oh my God, a lot of things that make sense now. These are the conference people usually go, choose one or two. You have to apply for travel rights. He told me, like all the script, how is being a postdoc at CAMH and UFT at that time, right? And then I didn't need any help anymore. I had the directions I was looking for, and I was not being clear what I want because I didn't know what exactly I was asking. But it was so important for me to have this person that saw that I was lost and gave me the script, right? So everybody that comes, I like to explain, this is what is missing, we need to work on that. Because in the end, to do the transition for this PhD to postdoc for a position, we need that. So if you know from the beginning, it's easy to prepare, right? And things continue to be like, okay, now I have all the things I need to go. But I was not having the same opportunities. I saw like the for some reason, like the things were not coming to me. So I saw like like, oh, we have like a travel award opportunity, but I was not receiving the emails. Some things not go direct for all the trainees, right? So as a PI, it's good that you make sure that as soon you receive an opportunity, everybody that qualify for that receives the information, right? So they should be able to be like the access to the same opportunities, to the same and I also something that was I was left behind, and was like when was like a grant application, they select a few people to help and not everybody. You may think, oh, good, you don't need to spend time write a grant, you can work on your papers, but I felt like why is not including me? Right, and because you learn so much when you write grants with your PI, right? So why not include myself, right? And then I was like missing this, and I think that still now I have a gap because I didn't follow the how to write a grant when my PI was getting a lot of grants, how to write a competitive grant, because I was not having this real life experience. Okay. Right, so so what we do, like in my group now, we put all the papers, grants from my grants, the students' grants, scholarship, we put all in a document and everybody can contribute. And we get surprised how much the students can contribute, how much is like genius. Oh my God, I couldn't have think about that, right? So everybody learn, everybody grows. We feel connect as a group, as we exchange a lot of information, right? So it's and it took for me some time to, okay, I should share, right? Because I was so do myself everything. So how much we learn as a group when we give the trainees space, they feel comfortable, they feel part of the team, they know their role, they know they are contributing, will be good for them, for the team, for the institution, right? So it's more you connect, more you want to connect with them, more you want to work together, and things just happen easier, right? And yeah, and I think one nice thing is to expose everybody from your team to these EDI trainings, right? Because we not cover everything, we are still learning, right? This is still a new topic. So as everybody goes for different courses, they bring this for the lab and help us, the PIs, the managers, and all the categories of the team members to learn more. And let's check that. Let's be more inclusive, right? There is ways to work better in this sense. So not give only the PI the function, but everybody get involved, learn, and make sure they are having the right skills, the right training. So I think helps to keep like things update and inclusive, right? So because this is my idea that so when we create this health and inclusive workplace, help to improve the engagement, retention, performance of the group. And with this united group, and then the creativity and the productivity will increase as well, right? So it's really important to spend some time to make everybody sense that they belong, they are important, even they are students in the classroom or your trainees in the lab, right? They feel comfortable and they can share with you whatever moment they are in their lives. We can learn together all the steps in science. That's a many, many, many steps, right? As soon as you are open to their well-being and the group well-being, right? Everything else will go well as well. That's my experience. Thank you. Question?
We will move on, I think, with Amy.
Okay, thank you so much. I really enjoyed that, and I'm enjoying this morning so much. All right, so I am interested in rare diseases. I think we all here are. So I get to talk to you about thinking about equity, diversity, inclusion for people with rare diseases. And I guess I wanted to start off with this figure, which is that 1 in 12 people, it's in Canada, but really it's in the world, have a rare disease, which is surprising, I think, right? So it's surprising to me when I heard that. However, there are really thousands of rare diseases, and most of these are invisible, right? I can't tell who has what disease in here. You all look perfectly healthy, but I know that we are not all healthy, right? I have my diseases. Everyone has their diseases. They're mostly invisible. So it's hard as a society to appreciate the burden of rare diseases. And I think that that number is really surprising. But still, for any one disease, of course, they're all different. And so there is a sense of isolation and really the taking care of people with rare diseases is challenging because for any one disease there are not as many people. We're not aware of how it impacts their life. So a lot of these are people who have rare diseases are they're really severe and disabling, and they're invisible because they're not even able to be part of society, right? So there's rare diseases where we can walk around and no one knows that we have this disease. There's also diseases that are so disabling, we don't even get to see them. And I think, you know, the mitochondrial diseases fall under that umbrella. So I'm going to list some of what I think are the problems that are faced in terms of creating you know, equity in care and inclusion of rare disease treatment in you know our mission, which is to help these people live healthier lives. So one of the problems is inequities in diagnosis. And most of these rare diseases have a genetic component. Some of them are completely genetic. Some of them are a mix of genes and environment, but genetic testing is essential to coming up with the diagnosis for these rare diseases. And it's really uneven who gets tested and who doesn't get tested. It has a lot to do with the country that you live in and their medical system. It has a lot to do with whether the family has enough money to get the testing. If the doctor doesn't prescribe it, some of them say, you know what, I know there's something wrong. I'm not satisfied with this general answer of we don't know, we can't help you. But that means that there are a lot of ethnic groups and countries that are not included. And so, of course, this is a big problem. This is a challenge to inclusivity. You know, it's tough even beyond that. Most of these variants, when you do the genetic testing, even that is not enough. There's a lot of variants of uncertain significance. So when you do the genetic test, it will come back and say, well, you have a variant in this gene. It's only seen, you know, it's seen like 1 in, 10 million people might have this variant. And there, you know, in 10 million healthy people, like it's super, super rare. It's likely that it's causing a problem. It's changing the spelling of, you know, your protein, but we don't really know if it's causing your disease or not because they're so rare. So they say, I don't know, maybe, maybe not. And yeah, and then of course for the mitochondrial diseases, some genetic tests are not even looking at those genes. So you can do all of this and it still won't address it. So I think a lot of this is just ignorance, you know, and I think that, I mean, it's forgivable. I don't want to put this on the clinicians, right? It's challenging because when a patient goes to see their doctor, it will very likely be the first and only person that they'll ever encounter that has that disease. So they're truly doing their best, but they can't know about every one of these 7,000 diseases. So, okay, so this is one problem, inequities in diagnosis. Another problem that goes along with this is uncertain prevalence. So a lot of times when you're trying to get funding, you're trying to get your disease treated, you have to tell people how prevalent your disease is. And when it's a rare disease, you don't know because a lot of people are not tested, they're not identified. And so you really don't know. You have an estimation, but you may only have 10 people in the world who have been identified and are part of a patient registry, right? So right now, I mean, there are pretty good estimates based on, you know, you think about the length of the gene, its tolerance for mutations, and whether it's something that, you know, can be passed on or whether it only occurs de novo because it causes such a big problem that people aren't able to, you know, have children really. So all of these things can give you some estimate. We really we can't even get at epidemiology and identify patients unless there's something called an ICD-10 code. And I think this is something that I've just learned in working in rare diseases. So the ICD-10 code is something that the physician puts in. There's a drop-down menu or, you know, where they say what this person has. So I work with people who have pathogenic variants in GRIN1. It's a gene. So when they get the genetic test, it says this is what caused your patient's problems, GRIN1. And they go to put it in, there's no code for it. So they can't put it in. They have to put in something like global developmental delay or autism or epilepsy, but there's nothing for GRIN1. And because there's not, that can't be tracked. They don't know where this person is. They can't then be part of a registry. They can't then be part of a clinical trial. When we go to plan a clinical trial, we don't know where the patients are. And we don't know where would be the best centers to do that, right? So if you don't have the ICD-10 code, it's a non-starter. And you know how these codes are decided? There's a group of people at CDC who decide every year. Yes. And if you have a genetic disease that doesn't have a treatment, why would you give them a code? There's nothing you can do for them. So our group, GRIN1, worked for a long time to get ICD-10 codes, and we wanted an ICD-10 code for every one of the GRIN genes. GRIN1, 2A, 2B, 2D. Also, there's GRIA1, GRIA3. So the genes that encode glutamate receptors, there's, I don't know, there's probably, how many are there? 10, 15 that are disease causing. We couldn't get an ICD-10 code for every one of them, but we have an ICD-10 code for GRI. So all of the GRINs, the GRIAs, the GRICs, at least we have a pull down. We now have an ICD-10 code, but we had to go, the patients, the caregivers had to go plead, beg, make their case. They had to get letters of support from clinicians, from researchers to explain why this was important, because we know that, like, from Angelman syndrome, or what is it called? The GLUT1 deficiency. So other rare diseases, there's a certain amount that find each other and become part of a patient network. But then when they got the ICD-10 code, their numbers doubled. So they went from, let's say, having 200 families in their community to now there were 400 who were identified, right? So that right there, you can see the power of the ICD-10 code and those without it, so that's a point of disparity that people don't know about. Okay, so this is why these patient registries and prevalence numbers are important for getting grants, for planning clinical trials, for convincing pharma that there's enough patients to make it worth their while to develop a drug, right? And then this, the fact is that no matter what, even if we can double them from 200 people to 400 people in a country, that's still pretty low, right? So there's only going to be a handful of people within driving range to the place where the treatment's going to be given, where the clinical trial could happen. And, so this is going to be something that's going to require multiple sites and international collaboration, right? So those are things that need to be overcome. Not that they can't be fixed, but let's just talk about the problems, right? So another problem is the drug development model, in the sense that it's very expensive, and, rightfully so. You want to make sure that what you give someone is safe, that it doesn't have contaminants in it, that you're not injecting them with bacteria that are going to give them sepsis, right? So everything that's done to make a drug, it's incredible, the process. So it's very costly for very good reasons. I don't think that we can cut down on the cost or all of the quality control for making a drug, but this is the reality, is that it is expensive. Okay, so I don't think that this is a question of let's make it cheaper, but we need to figure out how to do this, right? So whoever makes the drug, they have to have a large enough market size to offset the costs of that. So that can be done by having a lot of people where you charge a little bit for each drug, but it could also be a small group of people, but you have to charge a lot for the drug. And this can work in, where in countries where you have socialized medicine, where the government pays for it. So just to give you an idea of how this has happened for other rare diseases, this is an AAV treatment for spinal muscular atrophy, which used to be deadly, and children died at 1.5 years, 2 years of age. Now they're surviving and doing pretty well. Okay, so what's the market size for this treatment? It's $1.2 billion per year for the past 5 years. So they're charging about $2 million a dose. And then for DMD, this drug, they're charging, I think it's closer to like $3 or $4 million a dose. But these are deadly diseases where people would die, and they're now not dying. So you can convince pharma to do this, but then you have to figure out a way to pay for it. Okay. And then the last problem that I wanted to talk about is a problem in terms of inclusivity is lack of patient input into the research. And so let's say that you're a researcher and you decide, okay, I want to take care of this. Let's say you've always loved this gene, and then you find out there's some people who actually have a problem because of this gene. And you're like, oh, well, I can actually write a grant and I can help them. And I think that I can help them with this symptom, or this is how I think I would do it. But you never have a way to talk to these patients to find out what they actually want. And so you might go all the way to the end and then find out they don't want gene therapy. They don't want this. They don't want treatment for this. They're fine being in a wheelchair. They want to be able to talk to their kid. They don't care so much about whether they can walk, right? Because being in a wheelchair is not the end of the world, but they'd really like to be able to talk to their kid and find out why they're crying. Are they tired? Do they have an infection? Are they having a tantrum because they didn't get what they want, right? All of these things, you can imagine how hard that would be, right? So it wasn't until, well, I'll talk about that in the solutions thing. So, okay, so really patients need to be consulted and are not always, right? That's not the way that researchers think, is before I start any research, let's talk to the people that I'm trying to help. Okay, so I wanted to then talk a little bit about some possible solutions, and I think that these kind of forums could also come up with new solutions. There's still a lot of things we need to solve. So I think improving diagnosis and epidemiology might mean changing physician guidelines for when should they order genetic tests. It's done in, pediatrics. It's done in the epilepsy community is amazing for this. They're probably the best at it. It's being done for psychiatry, but not always. They're now doing studies with newborn genetic testing. And that's kind of expensive, but they're figuring out like, well, does this make sense? Because when you identify kids right away, then you can watch out for certain things. You can do certain things that can mitigate their symptoms. And they're also looking to see like, okay, what are the things that could help us decide who really we need to test genetically. And that could be, of course, babies who have epilepsy in their first year, but really any admission to the NICU or to the emergency room in the first year, right? There are some things, babies who have difficulty thriving, feeding problems, that like this list of things, those kids turn out to have genetic disorders, right? So why don't we just like prioritize and right away when they go to the NICU, we do a genetic test, when they have, when they don't hit some developmental milestone, send them for a genetic test instead of waiting, 2 years to say, yeah, they're really behind, maybe we should test them. So establish ICD codes for each gene or gene family. Just do it. Just do it. It's computer, like it's just coding in, we know all the names of the genes, just put them in and say the ICD code for GRIN1 is this, the ICD code for that's frustrating. The internet has been amazing to help parents find each other, to become experts. We could help parent organizations. We could teach them about kind of best practices for building a patient registry. Oops, there's someone calling in. What should I do? Decline it? Okay, sorry. Okay, no worries. Okay, so I think that there's a lot that we can do to really help these parent organizations. They are organizing themselves, and we can help them. In the same way, we could help them with giving them surveys and questionnaires in formats that then could be, coded and this can help them have the voice in directing the research, right? To understand how does this disease affect every aspect of their life, and what are the most disabling parts of that? They may not be what we as healthy people imagine that they are, right? Their most important thing might be getting a good night's sleep, right? And the doctors that's not even listed. If you say, what are the symptoms of this? Like sleep is like, well, that's not going to kill them. But for the parents, I can tell you it's killing them, Okay. Let's see. Then I think my last thing to think about, solution, financial considerations. So there are some ways that governments have worked to do this. They can give some incentives for rare disease drug development. They can do something like a voucher, where they will, if you're someone working on a rare disease, you can get a voucher to get to the top of the list for like regulatory review. And that can save you a year, okay? And so then that means your patent lasts that much longer. So the nice thing is that the government has allowed you to trade those. So you can get it, and that can give you an extra year. But they've also said, if you're doing a rare disease, we're going to give you an extra 7 years on your patent anyways. Okay, so you already get that benefit. You get 7 more years where you alone can make the medicine. But you could say, you know what? I'm going to sell this voucher. If there's anyone who would like to buy this, they can go to the top of the list. Now, if you are, let's say that you have a medicine for, I don't know, high blood pressure, and you have only, 5 years left on your patent because you've spent 15 years developing the drug, let's say, then that extra year, it could be worth $3 billion to you, right? So then you buy that, you get to an extra year on your patent, and that company gets all the money that they need to develop. So they sell for like $100 million. I'm not kidding. So that's enough to make a drug. That's enough to make a drug, do the clinical trials for a rare disease. So there are things that government agencies can do. The FDA was doing that. I think they might still be doing it for rare pediatric neurological diseases. So they've narrowed it, but a lot of these mitochondrial diseases fit within that. They streamline the drug approval process, and we need to think about are there new ways to make drugs that are less expensive? So lipid nanoparticles, the nanoparticles are cheaper to make. They're a little faster to make. They still have to go through all of the same GMP, regulatory process, but they might be less expensive. Okay, so I think that's all I wanted to talk about. I wanted to thank you to Mito2I and to MitoRevolution for funding my students and people in my lab. I wanted to say thank you to Cure Grin, and all these are the foundations that really I've learned a lot from them. And Combined Brain I just want to highlight, this is an organization that brings together rare disease communities. It's focused on rare diseases that affect the brain. And the idea is that we're all trying to solve the same problem. And so if one organization has figured out how to do this, they can tell all the other organizations, this is what worked for us. So this is how I learned about the ICD-10 codes and how important they are, by talking to people from Angelman syndrome and from GLUT1, where they went and looked at this data and saw what difference ICD-10 codes make. So I think it's a great organization. I'm glad of it because it brings together the patient groups, clinicians, researchers, and industry together to try and solve that problem. And so again, internet, amazing, is the key, I think, for a lot of this stuff. Okay, thanks.
Any questions?
Yeah. Yes. Yes, I agree. Yeah, there's so the I mean, I think the first thing is just to recognize the blind spot, and then we need to figure out ways to fill in that information. And I think that finding the researchers in those countries and communities where, genetic testing is not normally done, and then, doing some kind of thing where you say, okay, you are the clinician, you have the patients, and you can do all of the consent and everything like that. And then we can do the genetic testing here, but forming those connections, I think that's where we need some help finding each other, Yeah. Yeah, there was, yes, in the red. Yeah.
And knowledge to deal with in future, anything like a COVID situation. Through the lack of preparedness beforehand and until there was a great emergency that the government decided that we need like we need a treatment which is specific to these. And if you think that there should be a policy that funds research for like preventative things that would have everything in place so that the rush to find something once it becomes like a big problem.
I like that idea. And I think, yes, of course, but I think getting that message to people, and it's really tough to convince people to address the problems that we have right now. to even get them to think about foresight and think about like, let's prevent future problems. Yes, I want humans to be that intelligent, that they can be like that. Yes, I want that. But what I think about when you say that is, if you want to prevent a rare disease, why don't you insist on clean air and clean water and clean environment? Like that can help a lot. A lot of these things happen from mutations. And how do we get mutations? Like there are triggers that can cause mutations, and there are things that we can do to avoid mutations. And I don't know why people don't think about preventative health in terms of, if you clean up the air, clean up the water, clean up the food, that could give better health outcomes. But we can't, like, I don't know what to say. It's feel like shouting into the void. But thank you for that thought. Do you have other ways that how would you sell that to the Prime Minister, for example?
For example, the great figures like some protein in the brain. You would say we need to find for like an agonist for this protein.
Yes. Yes.
If to do this you know, prevent these types of like illnesses. We shouldn't have that in general or in any type of emergency, like, or something like that. But the many things, like with the COVID, the technology for the vaccine is statement, but it was that we didn't have the infrastructure or the need to like to really utilize it until it was necessary. There was something that says, hey, I have a drug that is an antagonist,
Yep.
protein X, Y, Z. They could be used for these applications, and we should think about like stockpiling them is to, you know, prevent or just like to, I don't know, to then
To be more nimble, to be faster. I think that there's some new genetic technologies that will allow that. And your example of COVID is a good one, because that technology of like the mRNA vaccines is also being used for gene therapies, in the sense of you can deliver a gene therapy. And, you know, if there's a lot of things that can be done fairly quickly. And I mean, there still needs to be the toxicology done, the safety stuff done. But you're right that having those manufacturing facilities in place and ready, and then the delivery system toxicology has already been done, and then you're really just looking at the cargo that you're bringing. So it's less that needs to be figured out. So it could be something that could be done. A gene-based approach can be more nimble and than making a small molecule for every single protein. So yeah. Should I probably should step back.
Okay, thank you. I think we're gonna move on with Kate. I'll put this one here.
Wonderful. And you're going to drive for me?
Yeah, I am gonna drive for you.
All right, you let me know when you want me to start.
We can start now.
Great. Okay. Good morning, everyone. My name is Kate Murray. I'm the CEO of Mito Canada. We're a national charitable foundation that supports, educates, and advocates for Canadians affected by primary mitochondrial disease. If you're not familiar, primary mitochondrial disease, or MITO as we like to call it, is a group of rare genetic disorders that impairs the body's ability to produce energy. And because every organ relies on energy to function, the disease can affect any system at any age. It's progressive. It involves multiple organ systems and causes symptoms like muscle weakness, developmental delays, seizures, fatigue. It can cause heart and even vision problems. There are over about 350 different mitochondrial disorders that live under the umbrella of primary mitochondrial disease. Each is rare or ultra rare and collectively affects about 1 in 5,000 people. But it's believed that this figure is an underrepresentation because primary mitochondrial disease is widely misunderstood and incredibly difficult to diagnose. So at Mito Canada, our mission is to energize and support patients, families, and healthcare providers across Canada through education, support, awareness, and transformational research. And every part of our work, one thing certainly remains clear, and that's patients want to understand research. They want to contribute to it. They see themselves reflected in it, but the path to participating in it isn't always straightforward. So this morning, I'll be presenting on how we can engage patients to engage with your research communities. And this is a really big topic. So for the purpose of this 15-minute-ish presentation, and from the lens of the mitochondrial disease community, I'll share a high-level view of why patient engagement matters, what barriers patient partners face in engaging in research, and how trainees like you can help build more accessible, inclusive, and equitable research approaches. So looking at this first slide here, so why does patient engagement matter? patient engagement isn't simply a nice addition to your research. Rather, it makes research stronger, it makes it fair, and far more grounded in real life. And a patient partner brings something that no data set or model can, and that's lived experience. They know what daily life looks like when living with the condition you're studying. They understand what matters to individuals living with the condition, and they understand what outcomes can actually change lives. So when we engage and include patients as partners meaningfully, we get better research questions, better study designs, better recruitment, and better translation. Could you advance slide there for me, Erica? Thank you. So for many patient partners, the desire to engage in research is absolutely there, but the pathway to participating can be shaped by a number of barriers. I've pulled out 3 here on the slide just for us to focus on this morning, being information and communication barriers, cultural diversity and trust, and the big one being accessibility. So looking at that first point there, information and communication barriers. Even when patient partners are engaged and motivated, contributing to research can feel difficult because information or language used in the research work we're doing can feel overwhelming. And a couple examples of information barriers are the use of technical or research terminology, or acronyms can make conversations really hard for patient partners to follow. So an example of this would be, fibroblast assays revealed a significant OXPHOS defect affecting C1 activity. It's very unlikely that a patient partner is going to understand that what that statement is saying is tests on skin cells show a serious problem with how the mitochondria make energy, especially in complex 1, which is the first step in that energy producing process. And next is research papers. They're long, they're technical, and the results are often heavy on data interpretation, and that makes reviewing materials intimidating for patient partners. Materials may only be offered in one language as well, which is typically English, which creates a significant barrier to understanding and contributing to the work for some patient partners. And then looking at the communication side, the communication barriers, patient partners aren't always sure what questions they can ask or worry about slowing the research team down with their questions. And when they ask questions, you may hear patient partners say something like, "This may sound like a dumb question," or "I'm sorry if this isn't what you're asking," or some may even just nod when they don't understand. And when patient partners hesitate to ask questions, it's not a sign of disinterest, but it can be a sign that the environment hasn't made space for them yet. And to a patient partner, these barriers can unintentionally signal to you that research is not for them, even when their lived experience is essential to your work. So how can you help break down some of these barriers? Well, the use of everyday words where possible, so avoid the jargon, avoid the acronym use, offer short, simple summaries of the work that you'll be doing together. Take your time to explain things in layperson language. Check in, use language like, "Does this make sense?" or "Can I break that down in another way?" Invite questions, and do it often to break down that power imbalance, that feeling of you know more than they do. And share visuals and analogies that help them make learning connections, because it definitely goes a long way. And translate materials into languages that represent the patient partner population that you are or that you are going to be working with. And from an EDI lens, clear communication really just help widen the circle of who can participate. And that includes our newcomer populations, people with lower health literacy, and partners whose first language isn't English. So looking to that second point, sorry, Erica, you're on the wrong slide there. Yeah, we're still on that one. So the second point is cultural diversity and trust building needs. So meaningful engagement means acknowledging that patient partners come from diverse cultures, histories, and lived experiences, and not everyone feels safe or represented in research spaces. For example, there's a lower representation of rural, racialized, Indigenous, newcomers, individuals with disabilities, or lower income families within research. And when patient partners don't see themselves in the room or on the team, it's easy to feel the research isn't meant for them or that their experiences won't be understood. Indigenous, racialized, rural, and newcomer communities can carry historical harms such as discrimination, unethical practices, and exploitation that really do contribute to a deep generational distrust of research. And patient partners sometimes feel out of place in research because the process can be to them unfamiliar or quite formal. And there's a strong use of academic language or there's a lack of cultural safety, which makes engagement feel intimidating. And then feeling out of place can lead to hesitation. It can lead to participation withdrawal or low rates of participation in the research work that you're doing, even when patient partners want to be involved. So how can you break down some of these barriers? Well, one is how you show up matters. Your language, your humility, your respect for lived experience, they all play a role in creating a culturally safe space that helps build trust. Showing genuine curiosity about people's experiences, but doing so in a respectful way. Using inclusive language, like using first-person language to avoid reducing your patient partner to their diagnosis and asking them what their preference is and respecting that preference. Also, avoid assumptions. For example, that all patients have similar backgrounds or similar needs or have the same level of disease understanding, because this really isn't the case. As well, don't assume you know what matters most to a patient partner. And I've lived this firsthand, even going through my own patient partner experiences with a priority setting measure, and it's quite eye-opening. And build trust by following through, being transparent, and explaining why your patient partner's voice matters to the work you're going to be doing together. And really, from an EDI lens, when you build trust, when people feel seen and respected, especially those from communities that have historically been left out of research, this is a positive note to take away. And then our last point there around accessibility barriers. Accessibility is a big one, but even with strong communication and trust, patient partners still face some significant real world challenges that makes participating in research challenging. For patient partners living with Mito, their reduced energy, their availability or their time, capacity, they're precious and they can be incredibly limiting resources for them. So some examples of accessibility barriers that you would consider is the fatigue or caregiving responsibilities may limit their time and energy. Unreliable internet, especially those who live in rural or northern communities. Limited data literacy or the lack of access to digital devices. Partners may have access to a smartphone, but not to a computer, which can make reviewing digital materials or collaboration documents or surveys incredibly difficult. And even accessing resources on cloud storage platforms can be challenging. And then the research meetings. Research meetings are typically scheduled at an academic-friendly time and location, and that can be a barrier for some of our patient partners as well. So how can you reduce some of these barriers? Well, you can offer flexible meeting times and do short check-ins. One patient partner shared with me that flexibility isn't about doing less, but enabling us to give our best, which I felt was a very insightful comment that I've always held close as I've done my own work in patient engagement. Offer virtual, hybrid, or phone options for meetings and workshops. And when you need to have in-person meetings, choose transit-friendly locations. Make sure that your materials are mobile-friendly. Again, not everyone has access to a computer or a laptop. Keep your forms and surveys and reading materials short. If there's a lot of content to share, break it out. Batching material helps make information certainly more digestible. And then walk patient partners through how to use digital tools or platforms that they'll need to use for review or collaboration materials. Don't assume that they know how these tools work. There's so many of them out there. Just best to take that journey and go step by step through how to use these tools and platforms together. And consider offering PDFs in addition to using a online or cloud-based portal when you're working together and you have resources to share. And another large component to accessibility barriers is the financial and unpaid involvement of our patient partners. So they often shoulder some hidden costs to participate in research. They may have to take time off of work, time that they may not be able to afford. They may need to find childcare. They oftentimes have to cover transportation or parking costs, which can be burdensome. And many times honorariums aren't offered for the hours of lived experience expertise that has helped shape research. So it's important to understand that compensation is about fairness. So include your patient partner compensations as part of your grant budgets, reimburse travel and parking and childcare where possible. But know that without compensation, only those who are financially privileged can participate, which is going to skew who shapes your research priorities and your outcomes. So it's incredibly important. And just wrapping up this slide from an EDI lens, accessibility isn't a convenience, it's an equity issue. Flexibility or flexible approaches help ensure patient partners with fewer resources have opportunities and a voice to shape the work that you will be doing together. Erica, could you advance slide there? Thank you. So we're going to move on to how you can empower patient partners. Empowering patient partners helps shape research spaces so partners feel welcome, they feel informed, and comfortable being part of the conversation and the work you'll be co-creating. And these are five key areas. Some will overlap somewhat with some of my earlier points, but they also speak to how you can empower patient partner engagement. So the first is communicate clearly. It's about inviting partners into your research space. Again, using plain language, avoiding jargon, avoiding acronyms. Share short, digestible summaries, a paragraph or two about the research, what it is, the questions you're looking to answer, why it matters, and what's still unknown. And break down complex ideas. Use visuals like simple diagrams, or our community loves infographics. And check in gently. If a patient partner looks confused, ask, would it help if I explain this in a different way? And then the second point there, ask early, ask often. Patients become partners when they feel their voices are shaping the work that you're doing. So consider asking questions like, what questions do you have? What matters most to you to help you understand the research, what we're doing? Validate their lived experiences. Consider language like, your insights help us see what data alone can't. And then our third point there, creating psychologically safe spaces, which has come up a couple of times this morning in our presentations, is for our communities, safety is felt when patient partners know they won't be judged for asking something simple. So use inclusive language. So instead of asking, do you understand? Consider, there's a lot of information and it's completely okay if anything feels unclear. Let's go through it together. Avoid assuming what partners know or don't know. It removes pressure on partners to admit that they're confused or that they don't know anything, that they don't know something about the research that you're working on together. So an example of language could be, I'm happy to walk you through anything at your pace. Leave space for partners to process information. New information and concepts are big, so they need processing time. And say it up front to set the tone right away. There are no wrong answers when you're collaborating with your patient partners. And celebrate the questions that they ask. Say, I'm really glad you asked that. And then our fourth point is be transparent. Transparency builds trust. Be honest about what is known and not known about the research that you're doing. Explain your timelines and expectations clearly. Share how patient partner input will be used. And follow through. If you say you're going to send something, send it. If you say you're going to follow up with a partner on something, follow up. And our last point here, make participation accessible. Even small adjustments can help patient partners who are juggling a lot. Offer flexible schedules, offer meetings and collaboration options like Zoom or phone calls, the short check-ins, emails, voice notes are helpful for our patient partners who have visual impairments, and use language like, let's find a time that works for you. Keep meetings short and focused, keep materials short and clear, provide language translations, and again, compensate partners for their time and expertise. Patient partners are the knowledge experts of lived experience. Treat them as you would treat an expert in neurology, cardiology, or gastroenterology. Could you advance slide there, please? Thank you. So the role of patient organizations. So organizations and foundations like Mito Canada already have trusted relationships and long-standing connections with patient partners in the communities they serve. We can help bridge the gap that researchers encounter when they're looking to connect with patient partners, especially in marginalized and underrepresented communities. So how can you engage with patient partners to support your research? Well, reach out early in the early stages of your project to forge a collaboration. Let organizations help you reach diverse patient partners, not just the ones that are close to your academic centers. Ask for help simplifying materials. Leverage the organization's written voice and reading style because their format, style, and voice are established and trusted by the community that you're looking to partner with. At the end of your work, reach out to your patient organizations who have assisted you to share the research results. They, in turn, can share your findings with the community, which also help demonstrate positive research collaborations. At Mito Canada, we have a knowledge hub called Mito Insights, and we create lay summaries of mitochondrial disease research publications in collaboration with the authors to support knowledge translation. And the goal is to help the family connect the dots between discovery and daily life, and to help the community understand the science that's shaping their futures, which is incredibly important. Could you advance slide, please? Thank you. So inclusive research starts with mindset, and this is what turns engagement into partnership. So components of an inclusive mindset: patients are partners at every stage of research, not participants at the end. Patient partner inclusion in your work has to be intentional, not just a check mark to meet grant criteria. So consider adopting a mindset of, how can their lived experience shape and strengthen the work that we're going to be doing? And lastly, research improves when it includes the full diversity of the community it serves. Sometimes it can be difficult to find certain patient partners. So again, leveraging relationships with patient organizations to include the partner diverse experience is incredibly important. And then could you just advance slide there, please? Thank you. And so my last slide here is about building a future for collaborative research. As trainees, you have an incredible opportunity to share what research culture looks like for the next generation. When building patient-partner relationships, show empathy, honor lived experiences. Partners have endured a lot and may carry trauma associated with those experiences, but they want those contributions to matter. Many patient partners have said, I'm doing this because I don't want others to go through what I went through. And some of our patient partners see their contributions to research as legacy building, which is incredibly important. Know that when you collaborate, you're creating spaces, where patient partners feel welcomed and valued. And remember that empowered patient partners don't just participate, they're going to elevate your research. They drive better questions, better outcomes, and better translations. So you have the power to make research more human-centered, more inclusive, and more impactful. And I have my thank you slides, so I hope you've enjoyed my presentation this morning. I would like to thank you and Anna and Sonia and the MitoRevolution team for inviting me to speak this morning, and appreciate your time. Happy to take any questions.
Thank you, Kate. Does anyone we have time for one question. Oh, let me.
Thank you.
Sorry, hold on. Boop.
Hi, thank you, Kate, for the talk. I was just wondering, you mentioned in your talk that creating summaries for papers and research articles in a sort of a accessible fashion. I was just wondering if that is where would that be able to be found? Is that on the MitoCanada website or?
I think I heard that asking about Mito Insights. Yeah, Mito Insights, if that's the question. It is on our website. If you look under our research tab, it's the very first one there. And Mito Insights was really born out of conversations that I've had with Anna. We talked about like how do we elevate knowledge translation to the communities? A consultation with our communities has been around, you know, they want to be able to follow along what the research is saying, but again, the research can be very academic and very heavy, and it's hard to get through. So these translations or layperson summaries have been incredibly important. And I have to say, they've also helped bridge or strengthen the relationship we have as a patient association or a patient organization with the research community itself. It's helped us reach larger research networks, strengthen the knowledge translation side of the publications that authors are responsible for. I even had an Australian researcher yesterday. We just finished her insights report, and she said, I'm completing my PhD and I would love to add this Mito Insights to my appendices of my PhD. So there's a lot of value to this knowledge translation mechanism that we have and with Mito Insights, and really want to encourage other patient organizations to be doing the same as well. Like we should be working in collaboration with our research partners. We want our community to stay excited about the discoveries that we're making in research, and we just have to help reduce that barrier to entry to understand by creating these summaries. So we've learned a lot, and we get to grow together and learn together as well. So it's been a phenomenal experience to have with both research and patient community.
Thank you.
Okay, thank you.
So our last speaker before we break for lunch is Gabriel. So I think most of you might know that we are having Indigenous engagement workshop on January 29th. So Michaela's going to give us a little bit of an intro and a sneak peek to that. And then we'll hear more about founders, really have that all that information that they can.
Okay. Oh, how far do I have to be to this thing? A little closer? Is that okay? Woohoo. Okay. Hi, everybody. Sorry, on Zoom, you were just seeing part of my shoulder. Hopefully that's normal. My name is Dr. Michaela Gabriel. I'm a clinical and counseling psychologist. I'm also Italian in Mi'kmaq, which is now known as Newfoundland. I'd like to thank, number one, everybody here for being invested and hopefully caring, but we'll see how that evolves over the slides, and the importance of talking about EDI and IR and you. I thought that was a fun abbreviation. I'd like to explore a little bit, and I'd also like to thank my fellow co-presenters, because a lot of what I'm going to be saying is going to actually be building off the importance for accessibility, diversity, also inclusion, but also how this really plays into Indigenous engagement and also Indigenous reconciliation. So hopefully it will make sense. Hopefully it's a bit of an appetizer before the January 29th event, where we'll be able to go in depth. I only really have 10 minutes and the lunch is here. So I don't want to take you too far away from where you might need to be or these other explorations, but I'd like to give a little bit of a background and exploration before we're able to explore things. But also keep in mind, this is not covering thousands of years of history, but it is looking and pointing the direction of why these steps are very necessary and how they actually will probably apply to you at one point or another. Okay, I don't know if anyone has seen this image before. It's very commonly used for distinguishing between equality and equity. I think a lot of people promote the idea of equality, wanting equality, having different things. But when we actually look at the science and literature, we understand that there's actually a huge deficit when it comes to our health realities, our lived experiences, our socioeconomic status, how that actually impacts the quality of health we receive in our lives. And our lived experience. So this is, again, a common example of understanding that equity is an informed decision that differentiates from equality to address these gaps through that meaningful lens. That becomes increasingly important when you look at the diversity of populations, how they access healthcare, how they experience healthcare. I have other quotes I can share about that, and the lived realities that face people. We think that, you know, the systems and experiences that we rely on for trust, support, and health, like if we're having a problem or we're in threat, we can call maybe the police, or if we're in danger or we are having a really bad cough, we can go to the hospital. But the challenges actually for specifically racialized groups, but especially Indigenous peoples, those are not safe places. And that can be very weird sometimes to wrap our minds around, that it can be something that we're used to experiencing safety in, or that we need to experience safety in. But the reality, through a lot of things that haven't been commonly taught in education systems, it's very much not. So that interestingly applies creatively to how we navigate and understand and interpret research. When it comes to diversity and inclusion, again, it's in the EDI framework, but just as a brief kind of cap, we have an understanding that there's awareness, inclusion, and engagement to outreach and address these voices, the importance of these aspects. And we commonly hear the words or the phrase BIPOC, so Black, Indigenous, and people of color, as understandably, unfortunately, racially inequitable across Canada, but also sexual and gender diversity. I'm a big believer, and I know Dr. Labuda is as well, of the more voices, perspectives, and strengths we have, the more we're actually able to help each other and go much, much farther. I often share this perspective that, and not to always compare humans to horses, but I think it's a really great metaphor, that certain types of horses, when they're trained together, are actually able to pull like tens of thousands more pounds of weight than individuals alone. And I think that's a really powerful understanding of just what we're able to do when we're actually collaborating together in a powerful way. We can go so much farther when we're able to integrate perspectives and realities that aren't our own. But this is where the IR comes in. Indigenous perspectives and experiences is actually recognized as separate from EDI. This comes from the history in Canada, the lived realities of Indigenous people, and a lot more that actually happens in politics and historical politics that I don't have a degree in, but I've kind of had to brush up on for this reality. The aspect is that a lot of people understand that it should encompass diverse groups, which means non-white groups. But the challenge is it actually differentiates or doesn't appreciatively differentiate the Indigenous realities. So again, appreciating that while we're on Indigenous territory, both ceded and unceded, the experience for Indigenous peoples as a governmental group, as a nation-to-nation collaboration through treaties, is a unique perspective and offers, unfortunately, unique aspects to how this gets played out in research, as well as Canada's obligations to Indigenous people. And that's where we see a lot of racism in social media comments and comment sections, is that people don't have that understanding. They don't understand the treaties and the existence of how that creates a very different dynamic for Indigenous peoples, and how we're not Canada's Indigenous peoples, we're Indigenous nations and the Crown. And that's two very different entities that are supposed to have political collaboration and support, but unfortunately through history have not. So people will also hear this definition of decolonization, or maybe you see flyers about it and kind of are wondering what it is. So decolonization is the active, multifaceted process that looks to identify how colonial structures uphold certain ideas of either maybe what well-being is, what success is, what health is, even what education is to some degrees. And it begins to explore how a certain perspective can infiltrate all those dimensions of maybe accessibility or even science. So, for example, when we think about science, and we're all coming from different labs, and maybe you've heard me say this before, we understand that science is rigor and hopefully ethical and procedural. But at the same time, for Indigenous knowledges and perspectives, we are very scientific. There's a tremendous amount that Indigenous knowledges in botany and has contributed to the pharmaceutical industry. But it's just that our science also includes the heart. So we include what it means to be an individual person when we're considering the impact of science. Just as Kate mentioned, we have to also be people and persons navigating health and well-being. It also recognizes and addresses that colonial structures, unfortunately, have commonly enforced one way of being, which predominantly across history sorry to say, has very much been success if you're a white man, less success or rights or history if you're anything else. So decolonization speaks to those aspects, speaks to identifying how those can inform our perspectives, sometimes subconsciously, sometimes consciously, and even as far as what gets talked about in the news. Indigenization, on the other hand, is the uplifting, inclusion, and incorporation of Indigenous perspectives and ways of knowing. And something I think that can immediately happen is when people hear indigenization, they're like, well, I might not be Indigenous, so this doesn't apply to me. But if you think about it, if we're raised in one way of seeing the world that may or may not be from our own cultural background, this is just another exploration or aspect of learning or seeing the world that could help us. It might be interesting. We don't have to necessarily follow or live or breathe something to understand it has value or to see from a different perspective. That's actually what makes a scientist, seeing things from a different perspective and understanding things and gaining new knowledge in a new way. Like Kate mentioned, a lot of this includes partnership and meaningful collaboration. Indigenous research methods can be included, but sometimes we don't always have that new knowledge set, and that can be challenging, but that's where partnership comes in, as well as a big aspect, which is inclusion of reciprocity and collaboration through research methods. This becomes especially important when we think about, as Kate had mentioned as well, the unethical practices that have happened across different historical groups when it comes to research. And I think we can sometimes live in a little bit of a bubble thinking that, you know, has research really harmed people? And then slowly but surely you dig through history and you realize, oh, this is another unfortunate vehicle of harm. Something, again, I like to keep in mind for people, or I like to advise people to think of, is the fact that for, you know, most Canadians, when we're consulting like the Canada Food Guide or nutritional supplements or how to have a balanced diet, those research, like the research that informed that, actually came from malnutrition and deprivation studies in residential schools, so starving children. So when we think that research is benign or can't have a negative impact, it can. And it's not only unethical, it's in the lived realities of many Indigenous peoples. So when a non-Indigenous researcher comes and shows up and wants to talk about either biobanking or, you know, different types of biomedical compounds, then a lot of red flags are going to go up. And if these structures aren't there, then understandably, you're going to take steps away, because not only is there a lack of understanding or a lack of inclusion, then there's not going to be asking the right questions that we need to ask and taking care in the way that we need to take care of either the data itself or appreciate the history that people are living with. So again, when it comes to Indigenous reconciliation, it's a different topic. It's a different kind of toolkit. It's a valuable toolkit, I promise you. It might make you more human, which can be a little scary, but I promise it's good. It is, unfortunately, I say unfortunately because people are like, not the Native stuff again. Yes, it's a necessity for advancing health equity. It's a necessity for that fun little apple picking thing I showed you, but also dispelling and correcting the needs of our reality as a society. I think most people like to believe that they're a nice person or trying to do good in the world. But again, it's very easy to dehumanize or other people that are like, well, that's not my experience. That's not my problem. I don't want it to be my business. Again, be really careful when you're reading about anything that mentions Indigenous people in comment sections. You see a lot of frightening responses. But if we also are trying to build towards something to take care of each other and address meaningful gaps, especially through research, then these are the sorts of things we have to pay attention to. And again, we're using, it's not big words, it's simple. It's Indigenous reconciliation and care, but in practice, it's just asking people how they want to be taken care of and what their needs are, and reflecting that their needs are going to be a bit different than ours. And that's human. That's totally normal and totally human. But it comes with a lot more gravity because there's a historical context where people haven't asked that question, and it's caused a lot of problems, and we're still trying to fix it. So with that very quick pathway, I'm actually done, which I think is great. So now we're close to lunch, even closer. I know I sped through this at warp speed, and there's oodles and oodles of wonderful minds in the room with different perspectives and experiences and training. And probably a question in your mind is going to be, how do I apply these things to my work? And we're going to find that out together. So I don't have that answer for you just yet, but we're going to keep exploring. But are there any questions just here right now while I'm here? Yes.
if you could recommend one place to get started, I'm particularly interested in indigenous ways of doing research.
Mhm.
I would love to learn more about that. What would you say? Go read this first.
There's a lot of really great works that are out there now, which is wonderful. I'd start with the foundational one by Linda Tuawi Smith, who's a Maori researcher. I think it's called Decolonizing Methodologies, but let me double check. Where'd she go? Yep. Decolonizing Methodologies. I think it was from the late 90s. Really wonderful work of just advancing that. There's more that have come out from there. I think it shows, and she's been a big promoter of the importance of kind of what we call researching back. So instead of trying to navigate different aspects of the complexities that come with other researchers constructing and designing and kind of creating the questions that are asked, she's like, or we can also get involved in research, and then there's people like me that shows up, and now I'm involved. So there's that. So I think it's a really important foundation, but there's a lot more books out there as well. But I think that's a good starting point. You're welcome. Anything else? No? Yay, lunch now. Thank you.
More about behavior research, January 29th, be a full day.
Yay. Woohoo.